So good morning, everybody. I hope you can all hear me okay. So I've got quite a broad topic as well. It was initially called Children's Health, so I've tried to call it OI Child Health during a pandemic. I will be talking about the implications of COVID-19 and really sort of an overview and a journey of learning for all of us. So this is an overview really, and I'm going to talk in very generic terms, but obviously relate that to some of our experiences with children and young people with OI and their families. So just to put this in context, so we know that this has been an extraordinary time, and COVID-19 is a unique context with enforced separation for all of us from all of our sources of emotional support, home, school, work, friendships, activities, etc. And we're all now completely aware of living through this. There have been sudden changes in financial situations, a complete change to normal daily life and routines. Many of us early on and ongoingly restricted to home environments, the changes that brings in parental roles, disruption to family and daily routines. I think I'm going to sort of highlight the sort of constant uncertainty for all, which for all of us is stressful, and for people and children with rare diseases and disability is accentuated across all of these themes really. And for some families with OI, we know that restrictions have been extended beyond national lockdown periods. That may be parental and family choice, that may be the often confusions about who should be shielding, who should not be shielding, and the worries about not only the child with OI, but the parent with OI, and so on and so forth. I'm going to try and just give key messages because a lot of my slides have lots of information, and Corinne, I'm happy to share them. But we know the principles of good healthy living, and Kasim has stressed some of those. So good nutrition and lifestyle factors such as physical activity and good sleep hygiene. We know that they have a positive impact on our immune function and how our body works, and our mental health, that enable us to resist infection. So it sort of seems counterintuitive that we've had to sort of hole up and, sort of go into hiding and all the rest of it really. So it's been very challenging to do even the physical exercises. And for those who have severe OI or complex disabilities, then there are huge barriers that have been put in our way to children and families because of this. Reduced access to local therapy input, no physio, no OTs because they've been deployed to other roles. Equipment, so specialist equipment, specialist seating, wheelchairs, sometimes they've been at school and not at home, no access to swimming and hydrotherapy, little access to wheelchair services, limited outside space, and just the sort of basic medical care, dental care we know is impossible to get access to. And then the access to community services and child and mental health services, with 2-year waits pre-COVID, and now those have been extended when actually there's a really, really key importance role for these services for us to continue to keep healthy. And underlying this is the fear of catching the virus, the fear of contagion. I'm going to plug vitamin D here. So, in terms of nutrition, yes, good nutrition and good, healthy, balanced diet, again, been very difficult to do because if you're stuck at home and, you're stuck in front of a computer or whatever, then you might want to eat more, you get more hungry. But nutritionally, simple things. So vitamin D, essential for good health, for our bones and for our muscles. It does have a role in immune function, and it does have a role in enhancing our resistance against respiratory infections. There is no hard evidence that it reduces the risk of developing COVID-19 or modifies its clinical course, but actually we also know that many of us are vitamin D insufficient, and again, due to lockdown, lack of sun exposure, periods of self-isolation, that's been exacerbated. So in terms of we should all be on a vitamin D supplement, in our OI clinics, we always say children should be on a vitamin D supplement, 400 IU, to 1,000 IU depending on age, and for those children on bisphosphonates, again, really important. But for all of us, we should be on vitamin D. The psychological impact, I think, just in generically, I think has been a huge impact on all of us, not just with OI, and we know that now there's many impacts on mental health for young people. There's been a doubling of referrals for eating disorders. We're seeing many children with physical manifestations of their psychological underlying disorder, tics, anxiety symptoms, physical neurological manifestations that don't actually have a neurological disorder. It's about the psychology underneath and the stresses underneath, and so many risk factors at societal level: social isolation, absence of interaction with peer group, food insecurities, disruption to routines, all the same themes that underlie these problems, really. And this is just one example, and this is not just our country, this is across the world. I showed this slide a couple of years ago when I talked on sleep, but actually for this, in terms of OI, then it's really important to say about fatigue, because fatigue and pain and fractures are part of having OI sometimes. And then just looking at the impacts on fatigue of fear and anxiety, peer isolation, activity levels, all of these will have been accentuated during the pandemic. I would say on the converse that some children have actually been in better health when they've been in lockdown, and their fatigue levels have actually been reduced, because actually the sheer effort of going to school, driving to school, being at school is effortful in itself. So for some, there have been positives and less impact on their general health, which has been better because of isolation, but the psychological aspects remain. So at GOSH, we've tried to identify some themes through OI psychology, and again, the themes marry up with what we know generically: so increased sense of isolation, being bereft of the usual support network in families and peer groups, anxieties about missed education, trying to teach as a parent, non-English speaking, trying to teach children with special educational needs. Again, the disruption to sleep because of lack of routine, lack of exercise, anxiety, young people's fear of infection, about their own health and their own health anxieties, and their parents, if their parents have OI, concerns about catching COVID, family bereavement, which permeates across all of us, the increase in parental burden and burnout, trying to manage all these things on top of sometimes if they have OI themselves, and trying to manage their own health conditions and their own stresses, and disruption of accesses to services with pre-existing mental health difficulties. So we've tried to implement video and telephone family triages and assessments and therapy interventions. We've put more psychological input in place, and the frequency of contacts has increased for young people. We've offered face-to-face sessions if that's what young people want. So we've done a mixture and a hybrid of how we do this. And we've also done a couple of introduction of online therapy groups, and also increased our interaction as a team with our therapy colleagues to try and understand, so that we can pick up young people with psychological potential who need psychological help. We've done a sort of tree of life narrative, which was a group-based narrative therapy intervention where we had 10 young people. It was online, age 12 and upwards, and that was jointly with GOSH and Sheffield, who'd expressed a sense of being alone with OI and wanting to share their experience. And it's building on the skills and abilities of those young people, and building a tree with this kind of, with the ground roots and the trunk and the future and who's important. And that was very successful, but everybody said that they would rather have it face-to-face than online. And then we've also introduced in the clinic the F words, which is to really enhance engagement of the young people and children within the clinic themselves, to talk about their fitness and function, friendships, family factors, fun and future, and enabling them to really participate in the clinic appointment. And we've and on the back of that, have been able to highlight and signpost children to psychology that have needed it. So at the beginning of OI care, at the beginning of the pandemic, there was much that we did not know. There was teen sickness. We all got COVID probably at the beginning of that. And fear of the unknown again, redeployment. We had to, try and work remotely and face-to-face. But we did maintain face-to-face contact with babies with severe OI throughout the pandemic, needing their treatment. We tried to prioritise that. We did weekly MDTs to keep the team together, and really sort of adapted as best we could to virtual and remote working, and a mixture of those. And there were local barriers to hub and spoke models of care. So a lot of our children who need treatment do that at local level. So we had to sort of adapt and learn, and perhaps switch over bisphosphonate treatment regimens to zoledronate, not for all, so that they were less frequent and minimising hospital stays, but tailored to the individual children. Education and teaching, often children were on wards that were not familiar with OI. So this is an example, this next slide, of posters to show wards and nursing staff of the bone fragility aspects, and coordination of clinics and diagnostics. It's extremely time intensive and labour intensive, but important to try and do. We've tried to prioritise children for orthopaedic surgery. Not easy, but those again that are more severely affected, who, if they fracture and then need rodding, it interrupts their care plan. So trying to do that in a timely manner. And transition has also been a journey. At first, our adult colleagues were redeployed onto COVID wards, so there were no transition clinics, but eventually we've kind of evolved, and now we're doing transition clinics with a mixture of face-to-face, and also bringing members of the MDT onto the virtual platform as well. We don't get it right all the time, and we're learning and adapting and trying to do our best to deliver safe and high quality care, but it's really, we're all in the same boat together. We make mistakes, and sometimes things don't go as well as planned, but we're trying to evolve and learn together. And then just, so I'm not going to go through this slide in detail, but again, from the highly specialised services, NHS England are looking at principles of good care virtually, because it's probably here to stay, but should not be the be all and end all. And part of the positives are enhanced access to getting primary care physicians, paediatricians on calls, so that we can share the care plans together, schools on video call or on video link calls, transition clinics we've mentioned, and also national cross collaboration has been, easier and more accessible, and therefore we can work across the 4 centres better. And then sharing management plans. Key to this is our clinical nurse specialists, to allow clarity and coordination of care plans and key responsibilities. So just in the last 5 minutes or so, Nick, I don't know if you've given me a warning. Not yet, I think. So COVID in children, just to specify that this is different to adults. And again, it is much, so children are at lower risk. They can be asymptomatic, mildly asymptomatic. They can have the respiratory classic illness, and they can have this very unusual hyperinflammatory response, which is in response to COVID, but not, they have exposure to COVID, and then they get a marked inflammatory response that can affect all of their body organs. They can be very ill, but we know now how to treat this, and they do get better. And the incidence of mortality in children is very low. So in this country, estimated as 2 deaths per million. We know that there are some children at high risk, and these are established in the Joint Committee of Immunology and Vaccination, JCVI, those with severe neurodisabilities, Down syndrome, underlying conditions resulting in immunosuppression, profound and multiple learning difficulties, and those with severe learning disabilities. So those are deemed at high risk. For long COVID, children do get long COVID, but actually it's low risk again. And in a recent King study, most symptoms for children with COVID resolve after a few days, and less than 1 in 20 had symptoms at 4 weeks, and only 1 in 50 had symptoms at 8 weeks. And there were a reduced number of symptoms over this time. Symptoms in children are different. Headache and fatigue, much more common, sore throat, and then you get the classic ones, and abdominal pain in younger children. And we've all heard about vaccination status. So the JCVI, so the Joint Committee on Vaccinations and Immunisations, are key decision makers, but they're weighing up the benefits to health risks. And at the moment, as you heard on the media this morning, the 12 to 15-year-olds, they're still kind of sitting on the fence a bit. The Pfizer vaccine is the only vaccine authorised for children between 12 and 17 years of age. There are common side effects with it, and now there are these very rare side effects of inflammation of the heart muscle and inflammation of the membrane around the heart. But again, rare and low risk, but are more common in the younger age group, slightly more common after the second vaccine, estimated in the States at about 60 people per million, to give you a view. Older children are more likely to benefit from younger for vaccination, and at the moment all 16 to 17-year-olds have been offered their first Pfizer vaccine, and the at-risk groups have been offered 2 vaccines, and children between 12 and 15 years of age at higher risk of the severe COVID illness that I've highlighted can be offered 2 doses at 8 weeks apart, or those that are in contact with household members that are vulnerable. So to summarise, humans are very resilient. We are resilient, resourceful, smart and adaptable, and children even more so. However, the effects of COVID will be long lasting on education, early development, with babies being exposed to not seeing the face, which is absolutely key in early development and communication, emotional and mental well-being. The long-term impact on children and young people, I don't think we know yet. Knowledge is a powerful thing, and the right knowledge, not conspiracy theories, evidence-based knowledge, and we've accumulated that. And I think uncertainty is dreadful to live with. General paediatric care for children. Remember, not everything is COVID. And I would say beware of complacency. Taking the easy option is not necessarily the best option. Everything takes effort, and we as healthcare professionals know this. It's very hard to put things in place, but we should be aiming for the best, and if face-to-face is best, then we should be doing that. We're inherently sociable beings, and virtual platforms are here to stay. But I think this is my view, but we should never, never lose the nuances of face-to-face interactions, our ability to read body language, building rapport with families, and as a clinician, observation of children and clinical examination is all important and will remain so. And I hope that we will be back to these kind of family groups, party groups of OI. And I would like to thank Evan here up the top and Rookie with his mask on for their permission to show me these, to show these lovely photos of them. So thank you to them, and thank you for your attention.